We are elated to have you here with us. These events, Dialogue with the Doctors, are such an amazing event that the White Dress Project puts on. We've done these on several occasions. And really the idea is for you to leave tonight's event not feeling so alone, not feeling so isolated in your diagnosis, and really having an idea of where to go in your fibroid journey as you navigate the medical care system, as well as what you can tell your friends. The thing the White Dress Project always says is we will no longer suffer in silence. And it's one of those things where once you get a diagnosis, you can feel very alone. And in reality, about 80% of women have fibroids. So you're not hardly alone at all. So this is a sisterhood. We're all in this together. And tonight's topic is Diagnosed with Fibroids, Now What? Understanding your treatment. We have a panel of guests for you who are going to explain their journey. Our patient advocates will do that and hopefully can take from their journey and apply some of what they have learned and how they've moved and navigated this to your own journey. And we have two doctors who can really dig into the treatment options that are available so that you have a wealth of knowledge when you go talk to your doctors about this, because that's truly key. Let's start by introducing you to our amazing panel tonight. Dr. Tiffany Jones is a fertility doctor and OBGYN. Dr. Jones, if you don't mind giving a brief introduction of yourself to our audience.
Hi, everyone. So I am a reproductive endocrinology and infertility specialist in Dallas, Texas at Conceive Fertility Center. I also am a fibroid specialist. I perform several procedures that we'll probably talk about tonight, and I'm so happy to answer your questions. Thank you for having me.
And Dr. Rochelle Wolf.
Hi, I'm actually a board member also of the White Dress Project, so I just have to kind of give a shout out to the White Dress Project. But I am an interventional radiologist. I've been practicing for about 15 years. I'm currently in the Minneapolis area of Minnesota. I actually have my own private practice outside of a hospital system, and I do a wide variety of procedures, but I have a special interest in women's health, in particular, treating uterine fibroids.
We also have two patient advocates joining us tonight. Let's start with Ashley Levy, if you could introduce yourself.
Hi, thanks, Adriana. I also want to thank the White Dress Project so much for giving me the opportunity to share a little bit about my story, which is quite unusual in the realm of fibroids. But I appreciate the opportunity to share it with all of you tonight because I think it is so, so important and really speaks to the importance for routine checkups after your procedures, that kind of thing. You'll hear why a little bit later. And I live in Madison, Wisconsin, and I actually just had surgery again 6 weeks ago now. So I'm well on the mend, doing good, and really happy to be here this evening.
Wonderful. And our final patient advocate and panelist is Nicole Jones.
Thank you, White Dress Project, for having me. It's such an honor. I just actually had an open myomectomy. It's been a journey with this. I also was able to carry my child, which it was a journey in itself, which we will talk about, with a 27 centimeter fibroid. We're talking about 9 pounds with a child. So to go through this whole process and to have my miracle baby, I'm so honored to share with you all my open myomectomy story and my pregnancy story.
Yes, I can tell you our patient advocates, what they have been through is absolutely amazing. It is very unique. And I'm so glad that the White Dress Project chose both of you to share your stories because it's in sharing the story where we can really learn from each other and learn how to navigate this entire process. So, without further ado, let's dive into the diagnosis and just, Ashley, I'll start with you. What prompted you to go to the doctor and how did you find these fibroids that you had?
So originally for me, this goes back, honestly, probably to about 2010. And I was having, of course, consistently heavy periods, just so much bleeding, to the point where even after seeking a diagnosis, talking about the constant pain I had, the feeling of bloating and pressure in my abdomen and my pelvis, getting to the point where I didn't feel hungry often because I always felt so full. Feeling lethargic. I didn't have energy to do the things that I was used to doing. And I thought a lot of that was attributed to the heavy periods. I became quite anemic, just didn't feel like myself. And it was actually a visit to the emergency room during one of my periods that helped get me to the right person where I was finally diagnosed. I had lost so much blood with one period that it put me in the ER. And that was a really scary time. I didn't understand what was going on. And up until that point, I had really gotten the brush off from any doctors that I had spoken with that, some people just have heavy periods, suck it up. This is just part of it. You're fine. And when I finally got in front of the right doctor, someone who specialized in women's health, all it took was her hand on my belly for 2 seconds before she said, I'm pretty certain I already know what's going on, but let's do an ultrasound. Let's make sure. We were going to do an ultrasound over the belly and a vaginal ultrasound. It turned out we didn't even have to do the vaginal ultrasound because my fibroids were so large. I was told I had the equivalent of a 5-month-old baby in fibroids. And I wondered, why did my belly look so distended? Why was I in pain? All these things. And so now I know these are all really telltale common signs that, you could be dealing with fibroids. And I am still shocked to this day that it took probably 4 years before I was able to get a diagnosis. And that's what
I was going to ask you was how long it took. Now, how old, if you don't mind me asking, how old were you when you actually got a diagnosis finally?
29. And everything moved very quickly after that time. I kind of had the opposite that I think many people go through. A lot of people are navigating fibroids on a fertility journey. And for me, I had always been very certain that my husband and we weren't going to have children. And so for me, it was the opposite. And it was trying to then, once I had my diagnosis, convince someone to, and this seems like strange to say, but to allow me to have a hysterectomy, because with the doctor I was working with, she was advocating that that probably would be in my best interest. We found I had 37 fibroids. That really big one was the largest one, but it was so difficult for me. And since I didn't want children, I wanted to do the thing that I thought would be best for my health journey and my wellness journey, which at that time seemed to be a hysterectomy. But you would be shocked at how many surgeons I met with who said, well, we need to talk to your husband. We need to make sure that this is really the decision that you want. You're so young. And it was, I ended up scheduling surgery for 2 weeks before my 29th birthday. So that's how I spent my birthday that year. But it was the right decision for me. And I knew it was, but I think I went through, it was the third surgeon I met with that finally seemed completely comfortable just hearing from me.
And not your husband, who doesn't have any periods.
Yeah. He wasn't the one having the periods. He wasn't having the pain. Right. So, that was an interesting and, again, very unexpected part of it. And that was in 2014. And I had a laparoscopic hysterectomy using a power morcellator, which is a little tool that's kind of like a blender. It's like a little tiny blender, and it grinds up the fibroids and then they're sucked out with suction. So that at the time seemed to me to be good. It was pitched to me as being non-invasive, a quicker recovery than an open hysterectomy would have been. The recovery time was shorter. They said that the pain would be more manageable. But what I didn't know at that time was that this power morcellator tool, they told me it was problematic for women who had sarcomas. So cancerous cells in the uterus and cervix, things like that. You wouldn't want to use that tool because it could spread the cancer cells. But what they were just starting to find out at that time was that that tool could actually spread fibroid cells as well. And so that's how my journey continued on to just a few weeks ago.
So I'm going to pause your story because I find your story absolutely fascinating, but I don't want to jump too far ahead. And I want to bring in Dr. Jones here. And, you know, when you listen to Ashley's story and you hear that she's been dealing with heavy periods, bloating, loss of appetite because she feels full all the time, you know, looks full and looks bloated, appears bloated. What is the delay for women in getting these diagnoses? I mean, 4 years, you know, and I feel like we go to the OBGYN fairly frequently. Why is it that the first time you go isn't a doctor saying, yeah, you have fibroids and we should really look into this?
Yeah, I think in my training, at least, which now is becoming a longer time ago, the first thing we typically do with abnormal uterine bleeding is patch it with birth control pills. So that's the, you know, oh, you're having heavy bleeding, try birth control pills. Not diagnosing the problem, not looking any further, just put a patch on it. Or, you know, if you're not needing a blood transfusion, it must, you know, kind of blowing it off as it must be, you know, normal. It's not that bad. But that really never made sense to me, because we should always be knowing what we're treating and not just arbitrarily treating something to see if it works, letting a patient go 3 or 4 months and then coming back when it's even hard to get back into clinics sometimes, because clinics can be busy, and then diagnosing it later on. Or then a patient then not liking that care, trying to establish care with another doctor. And then it just, you know, this is how we get to 4 years later.
And all the while, their quality of life is mediocre at best, just because it's treating a symptom and not actually treating the problem.
Diagnosing it, because birth control pills can treat, but like I should know I have fibroids. It shouldn't be 4 years later that oh, this is your diagnosis. You know, this doesn't make sense.
Mm-hmm. Nicole, I want to bring you in here and just tell us briefly about how you found out you had fibroids. What prompted you to say there's something more going on here than just a heavy period, which everyone seems to have?
I had a miscarriage, actually. I was about 21. I was married and I was having some symptoms. No, at the time I had missed my period, but I kept taking pregnancy tests, but it was too soon. And one day I just was not feeling well and I passed out. And next thing I knew, I woke up and I was bleeding a lot. And at the time, my ex-husband was like, we need to get you to the hospital. And I was like, no, I'm okay. I took a leave. I didn't know it was a blood thinner, thinking I'm like suppressing some of the cramps. And it turns out, because it was a blood thinner, it sent my pain from maybe like a 6 to 1,000. And now I'm in screaming pain. I get rushed to the hospital. And it was to the point that people in an emergency room was like, take her. It was like people with broken arms and everything. They're like, we don't know what's wrong with this lady. Take her. So they found out that I had a miscarriage and fibroids. And so we're trying to figure out, I said, well, you know what? I've been suffering a lot with a lot of pain during my menstrual cycle. What can we do? They sent me home with codeine. They were like, there's nothing much, you know, that we can do. And if you're wanting children, this is the best bet. And I was like, well, I really would like to look into it. They're like, well, you're still young. And I was at that time. It's been many years now. And I was like, okay. So I took the codeine and I went on with life. Couldn't get pregnant from then on. And I was like, you know what? If I do, I do. If I don't, I don't. I really shifted my mindset of how my menstrual cycle is. I just started celebrating it. I tried to start talking positive over my body, and I just dealt with it. I had a lot of bloating, a lot of protrusion that was from my stomach. And then one day I just realized my stomach was flat. And at that time, I was like juicing and eating correctly, working out. So honestly, I didn't go see the doctor. I just thought I was fine personally. And next thing I know, I got pregnant, But within less than like a week, I was showing so much. It didn't dawn on me that I could have possibly still had fibroid issues. I'm just happy that I find out during the pandemic, I'm pregnant. It's been what, at that time now, over 12, 13 years. And I'm not thinking fibroid. And so at that time, I'm feeling good, but I am pregnant. I'm in the pandemic. And I call the doctor. They're like, well, we have to wait till your 8-week checkup to, check on the pregnancy. I'm like, okay. And at that time, I could have possibly been about 4 weeks pregnant, around 4 weeks pregnant of, my calculations. But I was looking like I was in my second trimester easily, but still not thinking fibroid. And until I got to the doctor, that 8-week checkup, he was like, how far along are you? I said, 8 weeks, 9 weeks, I don't know. And he's like, well, you look like you're ready to give birth now. And I was like, yeah, well, I guess I'm probably the next person to, I don't know what, but I know we're going to figure this out. And so he did an ultrasound, vaginal and external, and he just started humming, just And I'm like, I just want to know, is my baby okay? And he taps me on the shoulder and he's like, well, I think this is a cyst. I want to send you on the other portion of the hospital to really identify. He said, if that's the case, we can go in with surgery because you are so early in your pregnancy, remove the cyst. I was like, okay. I still not thinking this could be even possible with fibroids. And here I am. Turns out I was 8 weeks pregnant, and the estrogen that I was producing doubled and tripled in pregnancy. Had no idea that was even the case. And it was feeding the fibroid that turned out to be 18 centimeters by 18 weeks.
Mm-hmm, mm-hmm. I want to just pause your story here, Nicole. And I want to bring in Dr. Wolf. It always amazes me, here's Nicole in the emergency room, bleeding. And, I guess obviously there's no gynecologist working in the emergency room but I just wonder, where is the disconnect between what seems, I guess, now that we have fibroids, what seems to be an obvious diagnosis and actually giving that to the patient at the time? Is it that this is not something that really doctors comes to their mind at first, or am I missing something?
That's a good question. Because again, I think us as physicians, I come from a different line of school in the sense that my background is a radiologist, I'm an interventionalist. So, if women come to me, they have heavy menstrual bleeding. I also get patients from, so I come from an imaging standpoint. For me, like every patient should have a workup. Everybody should have a transvaginal ultrasound. And for me, before I do a procedure, I typically recommend even an MRI because unlike a gynecologist, I'm not cutting it out. I'm not sending it to pathology. I want to know what I'm treating because ultimately I'm, basically cutting off the blood flow to fibroids and letting them shrink to help with the heavy periods. It's most commonly what we're good at. So I'm not, I'm a pretty big advocate for women's health. And there's a lot of entities that I treat in medicine that are equivalent in men. So same thing, women can have pelvic venous disease and things like that, varicose veins in their pelvis that cause chronic pelvic pain. And when we try to treat that and work with insurance companies, we get denials, but the same condition in a man called a varicocele, they get treatment right away and no question. So I think in women's health in general, I think there's a little bit of disparities in how those conditions are treated, whether you show up in an ER, whether you show up to family practice. I think women are just expected to deal with things and not complain. And there's been this culture of heavy periods are normal. And if you're going through multiple tampons, pads a day, I've heard stories of women wearing diapers, doubling up on tampons, going through more than 8 pads a day. That's not normal. And there should be a workup for that.
Right. I think during one of these events, a doctor joined us and said that, and please correct me if I'm wrong, but I think maybe you're supposed to bleed 3 tablespoons a day or something like that. And I have never in my life bled that little on a period. And it just blew my mind when that information was shared, because had I known that, I would have told my gynecologist when I first went to one, 100 years ago, like, look, I'm not bleeding normally. We have a couple of questions that I do want to get to before we get back to the patient stories. And these questions are for the doctors. The first question, one that we always get, is, do we know what causes fibroids?
There's a lot of theories, but we know that fibroids start off as one cell and they're tumors. And so usually what happens is there's some kind of genetic either predisposition that we really haven't identified specifically that we can target, but anything that rapidly divides or divides and doesn't stop and becomes a tumor is typically a gene that is defective that prevents it from doing that, because cells should not do that. We know that diet sometimes can affect fibroids. We know that estrogen can help them grow, just like Nicole talked about, and progesterone might slow them down or prevent them to grow. But we really don't know exactly why some women get them and some women don't. But because you see them more prevalent in African Americans, we do think there is a genetic component, and I hope it's identified and at least we can be screened for it in the future.
Dr. Wolf, did you have anything you wanted to add?
Yeah, no, I agree with that. I think there's definitely a genetic component, obesity, like estrogen. So any states that cause estrogen positivity, there's a link to vitamin D deficiency. But again, there's a lot of research also looking at things in the environment that may be causing exposures to women. And so, going along with just, that Harriet Tub or Stephanie Tubb Jones Uterine Fibroid Research and Education Act, because there's a ton of questions out there that still need to be answered. Mm-hmm. The White Dress Project, we're going to be working on a survey for women to find out what they want to know in regards to, diagnosis, causes, things like that, and hopefully try to direct either within us or outside of our organization some research directed towards those questions as well.
Mm-hmm. You mentioned estrogen and things that cause a rise in estrogen is possibly being linked to causing fibroids. And we have a question here from Cindy. Can hormonal imbalance be corrected to alleviate fibroids or shrink them?
I will maybe put that towards Dr.
Jones. We're deferring to you, Dr. Jones.
So hormonal imbalance is a little bit tricky because naturally someone with ovaries will produce estrogen. That's a natural thing. And so it's not really an imbalance. So our natural body, our natural hormones can stimulate these tumors. What birth control pills do, they don't slow it down. They have an estrogen component and a progesterone component. It really stabilizes the uterine lining and prevents bleeding in that way. It really doesn't address the fibroids or the underlying problem. It may help with bleeding. It may not in some cases, depending on where the fibroids are. But a hormonal imbalance, I would say that most people with ovaries don't have a hormonal imbalance. It's nothing wrong with your system. It's your natural system. And even as Nicole said, when you're pregnant, your hormones increase, and that increase can stimulate the fibroids to grow.
Mm-hmm. So let's move into treatment a bit more. And Ashley, I want to bring you back here in the loop because the particular treatment you had, you said one of the issues when they were telling you about this treatment was you weren't aware, and perhaps they weren't as aware at the time, that this treatment could cause fibroid cells to disperse in your body. And this is where your story just takes the most interesting turn. So if you could kind of start from that treatment on.
Sure. And, I saw in the chat, someone was asking if we could share what type of fibroids we had. Mine were all I don't remember the exact terms, but all the kind that were inside the uterus. And I had one that was peduncular, which is like the little stem. And then there's one. Normally with a hysterectomy where there's a larger incision and the entire uterus is removed that way, or you can do a vaginal hysterectomy where the uterus is removed that way. That wasn't an option for me because my fibroids were so large. So it would have had to be a large open incision. But as I mentioned, I was told about all the great benefits of the laparoscopic treatment. And I would say, I wouldn't want anyone to be nervous about having a hysterectomy if that's the right choice for you. I would still, hands down, have a hysterectomy again. But I do think if I had known that it was a possibility for my fibroids to recur because of the use of this tool, I would have chosen a different type of hysterectomy. I would have gone for the full open surgery because at this point, I've now had 3 of those surgeries. Each one has gotten progressively worse. So I had that hysterectomy with the Power Morse later in 2014. I was told at that time, once you have a hysterectomy and you have no more uterus, your fibroids can never return. They can't grow back. It's impossible for them to grow back. So I that was not seen a number of times. I was told I was just getting fat. I just needed to work on losing weight. I was told that I must have a pulled muscle in my pelvic area, in my abdomen, if I was experiencing pain, even though it felt to me the same. And it even felt to me at that time like I was having some ovarian pain. And I tried to describe that. And I was told, well, there's no way you can tell what your ovary feels like. You can't tell that your ovary hurts. And I said, okay. I really, that starts to weigh on you, start to believe that and think that, okay, I must be wrong,
I'm crazy. I'm having pain and I'm crazy.
Exactly. Yeah. It's a pulled muscle. It's a whatever. So, after losing about 40 pounds at that time in my life, because, I was told I was just too fat, and still having pain, it became more obvious that, again, my belly was distended, it was protruding, I was having all these same issues. And it wasn't until, actually, it was June of 2020. I had been out at the protests all day that were happening across the country, doing a lot more physical activity than I was used to, walking all day. And at one point, I grabbed my husband's arm because I just keeled over. Like my stomach hurt so bad. I said, you got to get me to the car. I can't take hardly another step. So I literally had to put my weight on him as we walked back to the car because my abdomen hurt so much. And I was really scared at that time that I thought maybe I needed to have my appendix out. I didn't know what was happening, really frightened. Went to the emergency room, was there, in the middle of the pandemic to the wee hours of the morning. And I was basically flat out told by the radiologist who was doing the imaging that I had ovarian cancer. Because after my hysterectomy, I'd had my uterus and cervix removed, but I'd kept both my tubes and ovaries because I was so young. And what they could see on imaging was really bad. So my ovary, where I'd been having this ovarian pain that I was told I wasn't having, my ovary was completely encased in a large mass. And so it looked like ovarian cancer. I went to my general practitioner a few days later who looked at the images. He said the same thing. Yes, we believe you have ovarian cancer. We're sending you to a gynecological oncologist specialist So, of course, I'm freaking out, thinking now I'm 35 years old and I have ovarian cancer, and what is this going to mean? And luckily, the specialist they sent me to is just a phenomenal human being. And he has had experience with women who are going through exactly what I've been going through and having a recurrence of leiomyomas or fibroids post hysterectomy caused by a power morcellator. It's not super common. It won't happen to most women, but the risk is greater than they thought. They thought it was a zero risk. They thought you could never have fibroids again. So what happens is when that little blender went in there and ground up all those fibroids, if even a single cell was left behind, that cell then becomes almost parasitic and it looks for somewhere to attach. And maybe the doctors can explain this better than I can. This is what I'm just like playing a game of telephone here with what I was told. But that little cell can attach anywhere else inside your abdomen and look for a blood supply. And once it finds a blood supply, it can then grow. So now it's been, 6 years since my hysterectomy. And I have 17 new fibroids attached to my colon, attached to my bowel, attached to my bladder, attached to my abdominal wall, one completely encasing one of my ovaries. So I decided to go in for surgery with a very amazing surgeon who specializes in this kind of work. And what was supposed to be a 4-hour surgery turned into a 14-hour surgery because they kept finding more and more and more of these fibroids. It's like everywhere he looked, even things that weren't showing up on imaging, they were finding more behind other ones or little ones that hadn't shown up. So I had to have a section of my intestine removed because the adhesion was so bad. I had to have part of my bladder cut to detach the fibroid and my bladder sewn back together. I had to have them cut off of my abdominal muscle, in my pelvis, in my abdomen, basically everywhere from under my breasts all the way down to the bottom of my pelvis was full of fibroids. And again, some of them very large again. And it was not what I was expecting. It was a very difficult recovery, like 10 times worse than my hysterectomy.
I would imagine there's a ton more organs involved. Dr. Jones, Dr. Wolf, listen, I am not a doctor. You all are the experts, but this sounds like a treatment that I wouldn't go for if presented with this. I mean, is this, Ashley did say that this is not extremely common, but my goodness, it sounds absolutely devastating if this is something that does happen to you. Is this type of treatment, is it still common?
So I want to first commend Ashley about being so well versed in what she has gone through to be such a great historian so that she can educate patients. There's nothing I need to fill in the blanks for because you said it and you said it all very correctly. Okay. And I think that's so important because our testimony will then help someone else. And so being a great historian is paramount. So what Ashley had is called disseminated peritoneal leiomyomatosis, and it's exceedingly rare. I will say that in this age, and I'm sorry if my camera is blinking, I hope you guys can hear me okay, but in this day and age, a lot of providers, a lot of gynecologic surgeons don't use power morcellators anymore. And if we do use power morcellators, we morcellate in a bag. We do that because, like Ashley so eloquently said, is that it can spread cancer, and I'm sure in her case, being that she was incredibly young, that was furthest from her surgeon's mind. But what is a rare condition that she has been affected by. And so, it's so dangerous because all of the organs that were involved, could have potentially been prevented if the morcellation would have happened inside a confined bag. So then that spread could not occur because this was almost like a cancer, that parasitic attachment, like it to have bowel involved, like it is similar to a cancer. It doesn't spread itself, we spread it ourselves with the morcellator, but that's incredibly rare, but incredibly dangerous. And so I I don't morcellate, but I do know people who still use that device, but they do it in a bag.
Wow. Okay. Ashley, my goodness, your strength and bravery, and as Dr. Jones said, this is why we tell our stories, because this is not something I'd ever heard of. And I never knew this could happen. And for anyone who's on this journey right now, if they talk to a doctor or meet someone and this comes up, at least now they have your story and that perspective. And I think that is very much key. Dr. Wolf, we're getting a lot of questions in the chat about hysterectomy. Why is a hysterectomy the first option presented to women with fibroids? And I do always want to add this disclaimer, a couple of disclaimers. It seems like for Black women, it's almost always one of the first treatments offered and stated and said. That's always been a problem in the Black community. But I also do want to note that for some women, for many women, I know a couple of women, they choose hysterectomy because that truly is what is best for them and for their quality of life. Now, as Ashley said, the women I know had to go to multiple doctors, and many of them asked, well, what does your husband say? Or what about, your future plans, et cetera? But I do want to acknowledge that hysterectomy does work for a lot of people. But Dr. Wolf, if you could just kind of explain, why is it always the very first treatment offered?
So again, the common realm of where patients go when they first present with, heavy menstrual bleeding is their gynecologist. They have a good rapport with them. And, there are multiple ways to treat fibroids, and they all have their pros and cons to those conditions. So it usually is, so I'm not a physician that performs hysterectomy, or so like I said, I'm very specialized in what I do with the uterine fibroid embolization technique. But I think it just comes around to education and having good conversations with your gynecologist. So, there's guidelines, and there is, talking to your gynecologist, knowing, am I a candidate for hysterectomy, myomectomy? There's even less invasive, laparoscopic, hysteroscopic myomectomy. There's now even more techniques where they can do radiofrequency ablation, the sonatas, the accessas, and then there's, uterine artery embolization. And so I just think in general, hysterectomy has been around forever. It is the most common gynecologic surgery done. Most commonly, it is done for benign disease for fibroids in the US. So, and I think maybe Dr. Jones can kind of chime in. I think when it comes down, I don't know why specifically that is, always presented first, but if, the uterus is gone, you can no longer have any more problems unless you're like Ashley, something really rare. But if the uterus is gone, the fibroids are gone, you're no longer going to have any more problems with uterine fibroids versus these other techniques. You still have a uterus, there's a possibility of having fibroids recur, new fibroids grow. So it really comes down to, patient expectations, size, number, location of fibroids, and then talking about at length all of those different treatment options, and then letting patients kind of navigate, what are the pros and cons of each and how that'll best go for what desires they have.
Mm-hmm. Mm-hmm. Dr. Jones, I didn't know if you wanted to chime in on that in terms of why hysterectomy is oftentimes the number one treatment offered. And then we are getting a lot of questions in the chat from people regarding why do fibroids come back if you choose a myomectomy or a different surgical treatment?
Yeah, so I think really all treatments should be offered to a patient with fibroids, and that would include a hysterectomy. Mm-hmm. The reason why it's pushed is more a patriarchal problem in medicine, where, if you're not going to use your uterus, you don't need it. Or even I've had patients who've never had children who have the tiniest fibroids, and you need a hysterectomy. Like, you need a hysterectomy. And I'm like, this is insane. So for those, I think that is malicious and unacceptable.
Mm-hmm.
But I do agree, just like what you said earlier, that for some people, it should absolutely be their option. But for everyone, it should be the patient's choice and not the physician pushing on. Like, I don't do UFEs. I don't do uterine fibroid embolization. I would refer to Dr. Wolf. But every patient that sees me for fibroids, they get a consultation about this is also an option, so that if they want a referral for that, because they should know all of the options on the table and then not make a decision right there, go home, think about it, pray about it, whatever you have to do, and then decide what is the best choice for you. Because it's not a choice for me. I don't even think a hysterectomy is necessarily that easy, so I don't know why it's the push, but sometimes it is malicious.
Mm-hmm. Nicole, I want to bring you back here into the discussion, because when we left you, you were talking about being pregnant with your child, and your doctor asking you how far along you are, and you're thinking a couple of months, and he's telling you, you look like you could pop any minute.
Right. Talking about a journey, it was definitely a faith move, because I saw the baby's little heartbeat, or how we left off, and something in me said, this is your child. You're going to have to, I know he's going to ask me, because here I am. They're doing the ultrasound. He's saying 18 centimeters. I'm like, I don't know what 18 centimeters is. Mm-hmm. And he said, it looks like you may have more, but because of the position of the biggest fibroid at that time, he really couldn't even measure it. That's how large it was. And he said, it looks about 18. And I'm like, I don't know what that means, but I'm just going to talk to the doctor and just go. And something in me I was calm. I was just calm about it. And I went home and I had a doctor's appointment the next day, because he wanted me to come back so we can discuss. And something in me said, he's going to probably most likely ask me to terminate this pregnancy. And I sat in it. I took a shower, and I was like, this baby's for me. So I don't know what that's going to entail, but I'm prepared for everything. So 8:00 the next morning, I see Dr. Smith, and he said, I got your x-rays back, and your ultrasound back, and it's about 18, maybe 19 centimeters. Is very large. You're very early in the pregnancy. I believe you should terminate. It's going to be a very hard pregnancy. I really can't tell you if you are going to be able to have this child. And I would hate for you to go through all of that. He said, it would be an easier thing for you to go ahead and terminate. Let us remove this fibroid. And then, then you can try to get pregnant again. And I looked at him, I said, thank you for your honest opinion, but what's the chances of me going through? He's like, very slim. I was like, well, I believe in faith. I believe in positive energy. So let's rock and roll. And he gave me the look like, what are you talking about? Do you not understand what I just said? I said, I do, but I also believe the power of my body. So I'd rather run the risk than not trying. That's what was best for me. And so he was just flushed at that moment. But when I chose him as a doctor, it was a referral from a friend. And it turns out his specialty is fibroids. And I think for him, he was just like, I've seen it all. You need to go with what I'm saying. And I went with the pregnancy. It was beautiful. I definitely went to the hospital quite a few times, a lot of discomfort. Like I said, the estrogen was feeding the biggest fibroid a lot. It came to the point once I made it to 20 weeks, which honestly, my doctor at the time, he's like, I don't even know if you're going to be able to make it to that 20-week mark. And I was like, well, I guess we're going to see. And we did. And I remember 2 days later, I had to be rushed back to the hospital because I was bleeding. Mm-hmm. And I was like, how's the baby? They're like, well, the baby is fine. It's you. I was like, well, let's keep going, obviously. They put me on some medicine so I wouldn't be going to contractions. I wouldn't lose the baby. And I did lose a lot of weight. You can see the fibroid. It actually was from my uterus all the way up to my rib cage. It was only on one side. And when I say it was uncomfortable, it was highly uncomfortable. It was very painful. And all I remember was I just had to keep going because it wasn't just for me, but it was for women who wanted to have the same experience that I had. So I prayed for strength and went through it. We made it up to 36, almost 37 weeks. And 2 days, she decided she wanted to come on her own. We did opt to do, I believe it was 4 weeks prior to do, oh my goodness, what was it? Steroid shot, just in case she did want it to come on her own. And thankfully, that was an option. I was a little concerned with the fibroid. And they said, well, the fibroid is already large. At that moment, it was 27 centimeters at 36 weeks. And so I was like, well, I'm already in it. So I was like, okay, we ended up having a C-section. Now, I would have to say that was the scariest thing because I had to contact my attorney because they wasn't sure if they were able to save my child's life and save mine. So the question is, whose life do we save? Because this fibroid is so large, if we actually cut the wrong way, you're going to bleed out. And I'm like, wow, this is really interesting. So when I got to the hospital, my actual doctor wasn't there because now I'm giving birth early. So we had his next chain in command. And all I remember is, oh my goodness, she doesn't know my story. She doesn't know the history. And this fibroid is so huge. Everyone thinks I'm having triplets. They don't know what to do. So thankfully, she called another doctor and hearing the conversation was very uncomfortable, because here you are with the C-section. Oh, we can't take the baby out this way. She's going to bleed out. We can't do this because the fibroid's here. Well, what can we do? So I'm like, if you don't know, what about my child? What about me? But I try to stay calm, in which I did. Thank God I had a good doula to really keep me breathing and going. And they took my baby out perfectly fine. Such a cute little yum. She's 1 now. She just turned 1. They could not remove the fibroids at that time because I had already lost so much blood during the C-section. So, which my doctor had already told me if, when this, success of the C-section is done, they would have to stitch me up. So I said, well, what would be the next option to remove? Well, he said 6 months later. And I'm like, okay, as long as I have my baby, fine. So I have little one. It was really interesting to go through that process of, giving birth and still having this very large fibroid, 9 pounds. Turns out I had more, but the biggest one, it was so big, it was about 9 pounds. And so I went for my 6-week checkup and he was like, so he just, touched my stomach. He's like, so you ready to get this thing out? I said, yeah, what are we? He's like, well, what about in about 12 weeks? And I'm like, I would just basically be healing from a C-section. And I was like, I think I'm ready. He's like, well, would you be okay with having a hysterectomy? Do you want children? And I was like, well, more children. I was like, well, I think I want the option. I'm not mentally prepared because I went through so much in that 9 months for an actual hysterectomy. So I gave him so much respect. He called me and he was like, I want you to go get a second opinion. And I went to this other doctor and he's like, I have never seen something this large before. And he's like, but I do believe that you can have an open myomectomy. And if you wanted to have that option to have another child, I will want you to get pregnant in the first year. So I'm like, okay. So I was talking to a few others about it. I still wasn't clear how many more. Our biggest concern was that biggest one, which was outside of the uterus. And of course, for me, I'm breastfeeding. I just had this newborn. During the pregnancy, I had lost about 40 pounds. So I wasn't gaining weight. I was losing weight because everything was feeding these fibroids. So I was very thin. I had lost a lot of calcium, a lot of bone density. It was just a lot of inner strength that I had to try to grasp at that moment. And now here I am having to get through this whole open myomectomy. So the doctor said, well, we will have to most likely cut way past your belly button. Are you okay with that? I was like, long as I'm living, I really don't mind. Mm-hmm. I was like, I don't see it as a scar. I see it as a story. So let's rock and roll. So he's like, oh my gosh, you're such a tree hugger. I love you. I was like, thank you. So here I am. It was basically, we hit 3 months and I had literally just started feeling better from that C-section. So I was a little concerned if my uterus was okay to go through this. We went through the surgery and I remember as they were rolling me in, which was once we, decided the open myomectomy is what I wanted at that time. They give me the anesthesia and everything, they're rolling me in, the doctor stops and he's like, Nicole, I do want you to be prepared once I'm in there that I may have to do a hysterectomy. And I just dropped. I'm like, you guys are rolling me in. I'm seeing the light and the light is about to go down and you're telling me about this hysterectomy. I think for that whole, situation, I think that was really hard because I'm like, my mind was set on one thing and now you're telling me as you're rolling me in. So I remember, the nurse, she was like, just know that he's going to do whatever he can. You're doing this for your daughter. And I was like, that is very true. They went in, I believe it was about a 12-hour surgery. They removed it. They did test, nothing was cancerous. But they found it was 5 fibroids. The photos are like astounding. So if anyone wants to see photos, I got you. But it was really interesting. He said, Nicole, we didn't actually see this larger one, which was like a size of a small watermelon in your uterus. We have no idea how we missed it this whole time. Mind you, I was going to the high-risk doctor during the pregnancy. They were doing the ultrasounds every so many weeks. No one actually seen this small watermelon size in my uterus. And so the doctor was like, honestly, Nicole, I really don't even know how you even got pregnant. And I don't even know how you was able to hold the pregnancy. Mm-hmm. And I could see him welling up. And to this day, it still wows me. He was welling up. He's like, I've seen so many stories, but I've never seen this before. Mm-hmm. And I was so happy at that moment that I advocated for myself. And I didn't understand what was truly going on. All I knew was I followed my gut. Mm-hmm. Don't know if it was going to be right for the next person, but I knew it was going to be right for me. Mm-hmm. So seeing the pictures, going through it, and now getting the chance to hold my little one, it's an honor that I was able to follow my gut, still hear the wisdom from the doctors, and for them to do whatever they needed to do. But I don't know, maybe I do want to have that hysterectomy later. I'm not sure. I just know at that time I went through so much. I wasn't prepared mentally to feel like I'm losing something, a part of my body at that moment. So I'm okay with it. I have a storyline. It's beautiful. My little one loves to touch it. And like I said, just seeing those fibroids now, it's appalling to me just to see this was in me and I survived. Yeah. This is a blessing in itself.
Yeah, 100%. That's a blessing. I mean, my goodness, you said it was a miracle. And yeah, I mean, that's a miracle that both you and your child survived. I mean, my goodness, I'm just so proud of you for trusting your intuition as well. And you got a good doctor who told you, look, go get a second opinion. A lot of doctors don't do that. And I think that a lot of times as patients, we go to the doctor because you're the expert. We trust you, and we'll take your word over what we're feeling because you know more than I do. So I'm glad that you advocated for yourself. I want to bring in Dr. Jones because you are a fertility specialist. I want to ask you a couple of questions about fibroids and fertility. First question is, will fibroids or can they prevent you from getting pregnant?
They can, some more than others. So just like Nicole said, the one that was inside her uterus, what I think she's saying is a submucosal fibroid. Typically, those are the ones that can cause infertility. And so an embryo implanting, it may not have a proper place to implant because it cannot implant on a fibroid, and sometimes not even near a fibroid. And then fibroids that are in the muscle can sometimes kink or block the fallopian tubes, and the fallopian tubes are the access point in which the eggs and the sperm, they meet. And so if you have one blocked, it may make you subfertile. They can also be so large that they pull the fallopian tubes away from the ovaries. And so the fallopian tubes have to pick up the egg from the ovary. And so if you have a watermelon-sized fibroid sitting in the middle of those, again, the egg and the tube may never meet. But the most common fibroids that we say are causing problems for fertility are the submucosal ones.
Okay. Is there a fibroid treatment, or does fibroid treatment impact fertility? So let's say that you find the fibroids, your doctor and you are well aware of them. We see them on the MRI, the imaging. Is there one treatment over another that you should consider if you're looking to get pregnant?
So again, it's where the fibroids are. So if someone has a submucosal fibroid, and I am so happy to see Dr. Linda Bradley in the chat. She is a pioneer for hysteroscopic surgery. And so that is the gold standard for fibroids that are submucosal. It's minimally invasive. It is a type of morcellation, but it's immediately sucking the fibroids out. And I haven't seen any cases of what Ashley has gone through in that form, because it's contained really inside the uterus. So potentially the fallopian tubes could be an access point to get out, but that would be exceedingly rare. But that procedure performed by an expert hysteroscopic surgeon would possibly let someone be able to retain their fertility and not have any incisions. When they are too large or too numerous, then my go-to is a myomectomy. And a myomectomy can be done laparoscopically, robotically, or in an open form.
Dr. Bradley, I'm hoping that I can bring you in here to this discussion because you've been very active in the chat and answering questions and really letting people what they need to know and ask and be aware of. Not sure if we can get you on camera. There you are. Dr. Bradley, let's just start with, when someone finds out that they have fibroids or they have heavy bleeding and maybe they're thinking this is fibroids, they go to the doctor. Yes, indeed, it's a fibroid. I want you to explain to people what are the questions they should be asking and what should they know? Because I think a lot of times it's very easy to visit Dr. Google and go down the rabbit hole of, devastation and disaster. What do you want people to ask and to be aware of?
I want people to have a physical examination with the speculum put into their vagina. I want the doctor's hands to do what's called a bimanual exam. In the era of COVID, and including at the Cleveland Clinic where I work, we are doing a lot of virtual visits. Almost no patient with exceedingly heavy menstrual cycles should be having all their conversations by phone. No. We are still in the hospital. We are still seeing patients, although for me, it's 1 day a week versus seeing patients Monday, Wednesday, Thursday for me, Tuesday, Friday surgery. So there are patients, you can have a prolapsing fibroid, a fibroid that is just coming out through the vagina that you don't see. So all the docs on this call, including the radiologist, you need to find a doctor with high skill set, interest, experience, who works collaboratively with their partners. This is not a I am the best, but it's a we as a collaborative team who knows the procedures like uterine artery embolization. Does your hospital have MRI focused ultrasound? Can you have access to something called Acessa, some new technology, Sonata, 2 new drugs that are available in 2020 and 2020 of May and June of 2021. Does your healthcare team know about this? I personally, and I'm very biased because I only do gynecology. I do not deliver anymore, but you need to have a highly skilled surgeons will give you the quicker surgery, the better outcome, the confidence that you need with surgery. And not every physician is the physician of choice because of the skill set. And it takes a lot of time, that 10,000 hours, as is often talked about in sports, about how you get good at your craft, whether it's sports, skiing, basketball. It's not just doing a couple of cases now and then. So I would say highly skilled physician at a facility that offers many options, that your physician is talented, has a ability to speak with you, and a pelvic exam and knowing the size, the number, the location of fibroids, and be able to liberally order MRI of the pelvis. I pioneered and coined the term SIS in the mid-90s, saline infusion sonogram. A regular transvaginal ultrasound for heavy bleeding is not enough. 1 out of 5 to 1 out of 6 intracavitary lesions and polyps are missed with a quote normal ultrasound, or you don't see the lining of the uterus. So I think in no other specialty except for gynecology are we so poorly attuned to evaluation with technology. If you, as I mentioned in the chat, if you are bleeding, a doctor is not just going to look at your urine. They're going to do a cystoscopy. If you have blood in your stool, they're not going to stop blood. They're not going to do like, well, let's wait and see for 4 months. You're going to have an upper endoscopy. So please know that every gynecologist is not the same.
True.
Okay, and I'm going to go on record for saying that. So I'm in a highly academic institution, as are other speakers on this call, and every doctor is not going to be the best for you, and you must be able to know the terminology as we're talking about tonight, to know what options you have, and to get the surgery with the most skilled physician and facility to offer the surgeries that many of the witnesses on this or testimonies on this call have done. And so I would say skill set, imaging, personal connection, confidence in your physician, and know that you do. Sometimes a second or third opinion is very critical. And all of us as surgeons, I'm sorry, I'm very adamant because I'm at a point in my career. Well, what am I going to say? Everybody is not the same. Okay, I don't believe that we're all the same in terms of training, interest, and expertise. And it is far easier for me to do a hysterectomy, quicker, everything else, than the skill set that's needed to do an excellent myomectomy that reconstructs the uterus to get you where you need to go, or a team of people, whether it's laparoscopic, robotic, vaginal, hysteroscopic. It's all very different. And my last point is that fibroids are unique and one of a kind, just like your thumbprint or snowflake. I'm here in Cleveland. They're not all the same. And somebody has a 19 centimeter fibroid can have horrible problems, as well as somebody with a 2.9 centimeter fibroid within the uterine cavity. So I'm going to ask women on this call, and my plea is to get smart, to get wise, to really study the healthcare provider and the team, because we're not the same, and everyone's interest and passion is not the same. So that's what I would say. And I can't remember the speaker. When your intuition feels different than what you're told, find another physician. Most patients with fibroids don't have cancer. It's 1 out of 350, 1 out of, some people say 1,000. It's a quality of life. I don't tell every patient, I don't save anybody's life. I improve the quality of their life. It would be in 30 years at the Cleveland Clinic in Cleveland, Ohio, 3 patients with leiomyosarcoma. Rare, but lots of trouble. Blood transfusions, IV iron, things like that. So get the best of care and find and work hard to find the team that would take care of you. And that would be my recommendation. No different than any other major health challenge that you would have in terms of looking for expertise in this domain. And those are my words of wisdom that I would give.
If only there were 1 million of you placed around the country for people.
There are lots of people. There are lots of people. There are lots of people. So this is not about me. I mean, I just think that people have to look, do a little bit of homework, just like we do. Look, getting a hairdresser, getting a plumber for your house. Who's the best? Housekeeper, you name it. When we want to find the best for something, we will find it. And your health is no different. And so there are lots of people that are passionate, young people that are coming out of training that really want to devote their time. So I'm going to put you at a little bit of a challenge for that, because I think women like those on this call have somewhat demanded that we step up and step out and stop just offering hysterectomies as the only solution. We do a lot of hysterectomies, but it has to be the right patient and the solution for whatever they're looking at and the outcome that they're looking for. It can be the right choice for a patient. But I would say this, I keep saying this is my last thing, but if you want a baby, then you need to find the doctor that can offer you a myomectomy, however it's meant to be for you. And, that's what I would say. And so you just got to do a little bit of homework and have your questions and go by what your heart is telling you. I think is very, very critical. And our partners, the radiologists, we've had a program at the Cleveland Clinic since the early 90s and it's not about but I have over 1,000 patients who have successfully and have written about it and researched this and published my data about outcomes from uterine artery embolization. Great procedure for the right patient, wrong procedure for the patient who is looking for certain kinds of things. So you just have to have a very, very knowledgeable team. And we are at the Cleveland Clinic, a team of teams. Everybody doesn't do everything great, but we know within our minimally invasive GYN surgery subset, who's the best at X, Y, or Z. And we rely on each other to offer the services that maybe I don't do 1 million of and somebody else does 1 million of because that's their interest. And that's how I think you should look at your health and know that you have choices. And to me, I just think as I've gotten older, I have to say this, it would be so unfair for me not to say that. And you just have to work hard. It's not even that hard. You guys now have the internet and Google and virtual visits you may set up as a first visit with a physician and then move on. But yeah, those would be the things that I would say.
Well, I think what you mean when you say work hard is to advocate for yourself and arm yourself with the knowledge. And when you go to a doctor, don't necessarily take that first doctor for their word, but like you said, find a team of doctors that can collaborate with each other and with yourself and be your own advocate. Right.
Absolutely.
So I want to make sure that we are hitting all of the treatments for people. I know there are people in the audience who are really concerned about fibroids and fertility. And Dr. Jones, you mentioned the best option for those who are looking to preserve their fertility. We had a question in here about holistic treatments for fibroids. Oftentimes we get questions about, is there something I'm eating or something I can eat that can help shrink fibroids? Can you speak to the non-surgical treatments, if any?
Are you speaking to me or the other? Because I just happen to be, I love this group, the White Dress Project, and I just happen to have a little bit of time to be on the call. So I'm not here to dominate this call. I was not an invited speaker, but I could not say something on the chat. So I'm just going to sit back and let the other speakers speak. And I do want to just say one thing. I was a part of one clinical trial, and I can tell you it doesn't matter because both clinical trials did this. In these trials, 68 to almost 70% of women on the oral therapies were Black or women of the African diaspora. You look at some of the studies like Ulipristal started in France, 5% of the participants with small little uteri were included. When I was a part of this trial and we put this together, I said, I want all takers. We need to include women that look like the women I take care of. Yeah, it's not the little tiny puny little uterine women who weigh 100 pounds. I want all takers. Yeah. I don't care how big it is, how much blood they lose. So the trials look like the women that are probably on this call. And those are medical trials. Mm-hmm. And so I want to always thank the women and the research nurses who participated in these clinical trials. I see a few little notes here. You know, any trial has a time limit to get approved. Right now, the time limit for these drugs is 2 years. Mm-hmm. Okay, look at the Mirena IUD, started in 1999 when it was good for 3 years. We know it works. Just recently, the FDA this summer says it's good for 7 years. So I don't want to be a naysayer with these two new drugs that are available. 2 years, we got the studies done, excellent completion rate, excellent outcomes. So yeah, it's 2 years right now, but as we move forward, like the IUD, we get smarter, we get better, we get good outcomes, and those drugs may be extended for use. So we have to start somewhere. Mm-hmm. And these two are the only drugs approved for the true treatment of fibroids. Everything else, birth control pills, Motrin, even Listet, tranexamic acid, were not approved, although we use them off-label for symptomatic treatment. But know that you have two drugs, medical drugs, by two different companies who have done excellent clinical trials, including a very diverse patient population, to say that without meeting the criteria, these drugs would have never been approved for safety, efficacy, and outcome. And one person on the call did ask about another who has a DVT or blood clot. There is yet a third drug. I'm also involved with the clinic, just interested in this, but stay tuned. One of the new GnRH antagonists will not have add back with estrogen or progesterone. And if it's approved, which I think it will be in the next year, will be another option for women who have those risk factors like breast cancer or having a blood clot in the leg or lungs. So this is a big area. I am in Cleveland. I'm a Lynx member. And when I joined the Lynx many, many moons ago, Stephanie Tubbs-Jones and I, quote, went over together. And unfortunately, she passed away. But what we're looking at in terms of fibroid research and fibroid, getting more research dollars. I knew Stephanie. I'm in Cleveland, and we're just going to get smarter. And there's been a demand from women to say, are there other things? So don't give up. Keep looking for right provider, right procedures, and go by what your heart is telling you.
So Dr. Bradley, I'm going to ask if you can get into the chat and type out the names of the drugs that you mentioned so everyone can write it down and be armed with that information. We're also having, someone has asked about Lupron for the treatment of fibroids in shrinking them. Do you or Dr. Jones or Dr. Wolf have a take on using Lupron to treat fibroids?
So Lupron is a GnRH agonist, which basically means it shuts down the pituitary's action to help ovaries produce eggs, and in that estrogen levels going up. So it's kind of like a chemical menopause. Okay. So I see in the chat, people were saying, I took Lupron for X amount of months and my fibroid shrunk millimeters and I had hot flashes, night sweats, weight gain. And the thing about Lupron is I don't use it to really shrink fibroids. Yes, it can soften them, maybe shrink them a little bit. I don't personally use it, but that is, the thought. But once you stop that medication, then the fibroids are going to go back growing just as they were before. And using it for a prolonged period of time, because it's decreasing your body's natural estrogen production, that can harm bones. So it's not a long-term therapy, and it's really either a bridge to menopause. I used to use it in that way back in general gynecology. But for surgical management, I think most people probably don't use it in that way anymore. I'd love to hear Dr. Bradley's take on it.
Well, yeah, I would agree with you. I think currently the GR, and I listed the names. I don't know if we're supposed to, but someone asked Orion, and the other is Myfembry. The other one is not available. One is twice a day, morning, evening with Orion. It came out in 2020, the summer of 2020. And then Myfembry is once a day. And what we're getting smarter about in doing secondary analysis with is the study was really done for heavy menstrual bleeding. But because of the way that the medication works, we're now doing secondary studies of the same patients to see if some of the issues with pain, the size of the uterus also improves, even with something called adenomyosis, another condition that mimics fibroids. So what happens in clinical trials, you throw a wide net and you say, what do you want this drug to prove? The biggest complaint is heavy bleeding. Then you have pressure and pain and looking pregnant. So we are involved now with those secondary outcomes to say, can I get on a call like this and say, your 20-week size uterus or 25-week size uterus is going to become the size of a 3-month pregnancy? I can't say that right now, but what we can say is that there's a high response rate for women whose chief complaint is heavy menstrual bleeding in terms of it treating that. And so all I'm saying is just stay tuned. Things are, and then doctors start doing secondary studies outside of the clinical trial to look at outcomes. And so for right now, it's really meant for heavy menstrual bleeding. Other kinds of things are more, I would say, anecdotal, and we are not supposed to go out and lecture that it does this, this, and this. But I can just tell you it's such an interest, and folks are starting to look at either what we consider non-responders in terms of how the definition was reached for the drug trial, but maybe they were non-responders, but their quality of life is better. And so maybe it's going to be better for more patients. So I'm not sure if that answered the question.
We are running out of time, and I hate that because we could talk about this for a long time. But I'm so glad that the doctors are able to join us. And we have posted their social media handles in the chat, and I encourage everyone to reach out to them on social media if you have further questions about their specialties and your treatment and what you should know as you go through this journey and as you're talking to your doctors. So again, their social media handles are there in the chat. What I'm going to do now is ask all of our panelists to just in a minute explain to the audience what you want them to know about being encouraged on this journey. Maybe it's something that you wish you had known. Maybe it's something that you share with other people who are on this journey that you want to share with them. But Nicole, I'll start with you. What would be the takeaways that from your journey that you want to pass along?
To really stand in your truth and stand in your power. And I feel like as women, sometimes we hold our own self back. And I think this is like more time than ever to really tap into your intuition tap into what you feel it's right. If you feel like you need to dig in more information, get that information. Don't feel like you're crazy, and really be connected with your body. And sometimes you have to remove all the noise around you and really listen to yourself. And you honestly, the answers are right there for you. And I'm so happy that I was able to do that for myself. Is just really, because you hear so much, you are scared, you are questioning because something can be invading your body. But the true answers is always your gut feeling. So rise above, walking your truth, standing your power, and whatever's best for you, that's for you and nobody else. That's it.
Nicole, thank you so much for sharing your miracle story. And tell me again what you called your scar. You didn't call it a scar, you called it
it's a storyline.
I love it. I love it.
Send in peace and light to everyone.
Ashley, your story is so fascinating. Talk about twists and turns and a hell of a plot. What would you want people to take away from your journey that they can be armed with as they go on their journey?
I would definitely love to echo what Nicole said about kind of standing in your truth and in your power and making sure that you're advocating for yourself. I think if I had done a bit more of that, I probably wouldn't have had to wait quite so long for treatment and to move a little further down this path. And I really, really would just like to encourage everyone here to listen to your body. And if something doesn't feel right, push for imaging, push for multiple opinions. Like so many of the doctors have said tonight, get a second opinion, get some imaging so you know what you're working with, so you know what your options are, and ask, excuse my language, but ask a shitload of questions. Ask a shitload of questions. Ask what all of your options are, not just what you're presented with, maybe in those first few visits. Ask, are there other options available to me? What else can I do? Mm-hmm. Because I think there is always a way to get what you want and need out of your treatment. And it just takes a little perseverance. And even if things don't go to plan, like they certainly didn't for me, just know that there's always more you can do. There's always more you can do. There's always something else you can try. And the journey might not be from point A to point B. It might not be very straightforward, but you'll get there. You'll get there.
And one thing I would add to what Ashley says, because I think you're so right in terms of advocating for yourself and asking a shit ton of questions. One thing I have learned to ask, and I think a younger me might have felt like it was offensive, but I will ask a doctor, is there someone else who's more specialized in this, who has more expertise in this? And if a doctor is offended by that, well, I don't need to come back and see you anymore. I need to go off and find someone else to, pay, because it's your money, it's your time, it's your body, it's your health. So ask all the questions, even the ones that might seem offensive or stupid or whatever. Dr. Wolf, anything that you would like to add? I think that a lot of times as women, again, we just trust the experts and go with what we're told. But what would you like people to be armed with as they start or as they're in the middle of this journey?
So again, I think being your own advocate is probably the most important thing to do. I always tell patients, if there was one best way to treat all fibroids, we would only have one way. Mm-hmm. And I also tell women, the human body never follows the textbook. That's why it's the art of medicine, not the science of medicine. We need science, and then we need to tailor all treatments to the patient's own symptoms, expectations, lifestyle, and all of those things. So when you reach out to a physician, I think, so the procedure I do is uterine fibroid embolization. It's also called uterine artery embolization. I did a play on words with those letters, UAE. When it comes to women's health, I say unite, advocate, and educate. So I think it's the three things that we need to do. So when you seek a provider, like I said, I don't do myomectomy. I don't do, hysterectomies. But I've empowered myself to know at least enough to look at a patient and say, yes, you're a candidate for those procedures. Yes, you're a candidate for uterine fibroid embolization. Here's the pros and cons, but here, go have a second opinion with your gynecologist, and together we can make the decision that's best suited for you. So if you go to a physician and they say, you can only have a uterine fibroid embolization, or you can only have hysterectomy, or you can only have myomectomy, you're probably not at the right physician, because they truly are presenting you all your options.
Mm-hmm, mm-hmm. And lastly, but not least, Dr. Jones, briefly, your takeaway for people as they leave tonight.
I would say it's really best to arm yourself with as much knowledge as you can before and after your appointments. Like Dr. Bradley said, and as it's been echoed, getting a second opinion is almost paramount. You can always come back. Patients get a second opinion from me. I actually refer to a lot of different colleagues that perform things in a way that I cannot, because it is not my specialty. It's not an ego thing. It's what is best for the patient sitting in front of me. I worked at a practice where I got in trouble for referring out. And it's like, this is what medicine is. It's not about a business. It's about this person and what they actually need. And if I can't provide what they need, then I need to get you to a colleague that is best suited. Mm-hmm. And the patient doing their research, because it's really ultimately going to affect you, is the most important thing you can do for yourself. You get information, you take it, you research it. Yeah, people get scared of Google. I'm not scared of Google. Google it, but ask me about it. Let me re-educate you or reaffirm what you have researched for yourself, because whatever you choose, you have to live with and deal with. And there are lots of ways to get information in this day and age.
Absolutely. So I hope, when we started this and I did the opening statements, I said that the goal of tonight is for everyone to leave a little bit more educated, armed with information from hearing other stories and taking that information and applying it to your own. I certainly hope that you all feel that that's what you're taking away. These events hosted by the White Dress Project, which I just cannot say enough about that organization and their advocacy and the work that they do, and events like this, where you just get, so much knowledge from the experts and this sisterhood that you have access to. Can't say enough about the White Dress Project, but I'm hoping that you all feel empowered leaving the event tonight. Again, the social media handles are in the chat. Reach out, get more knowledge, ask all the questions, a shitload, a shit ton, ask them all. With that, I want to say, Kim and Tanika, thank you for including me as always. I certainly appreciate being a part of the organization and events like this. And I'll turn it over to you.
Thank you so much, Adriana. We can't say enough how much we appreciate you, your support, your friendship. You're always there when we call. So thank you. And I want to thank Nikki as well. I also, of course, want to thank all of the panelists. Ashley, Nicole, your stories are so moving, so empowering. A lot of times we hear from our community how our page is so empowering, informative, insightful. But truth be told, we get a lot of that information from the stories of our community. There's no way that we can do this work without your stories. And I know it takes a lot of courage. It takes a lot of vulnerability, a lot of strength to be able to share your story, something that's so personal with the world. But I want to thank you both for giving us the gift of your story. And like you said, Nicole, like you said, Ashley, it is so important to continue standing in your power and standing in your truth, and not to let anybody dim that. So thank you so much. And definitely thank you, Dr. Jones and Dr. Wolf, for your insight. We cannot do this work without our physicians working alongside with us. So thank you to everybody who is in attendance. I was trying to, go through all the comments, and one of the resonating themes is, I'm going through this. So thank you so much for this discussion. We need to have more of these discussions, and we will definitely have more of these discussions. And I'm thinking we should have a part 2 of this particular discussion, because there's just so much to unpack with this topic that we really can't get to in an hour or an hour and 30 minutes. So we'll definitely be having more of these. So look out for that. And I'm just sending everybody, oh, Dr. Bradley, can't forget you. Thank you so much for, taking time out of your busy schedule to join our conversation and to provide such invaluable wisdom and insight. I'm on my treatment journey right now. So I've learned so much being a part of this as well. So thank you all. And I'm just sending everybody so much love and light, healing prayers, positive vibes. We got this. So thank you. And I want to turn it over now to Tanika.
Hi, everybody. I don't want to take any more of your time. I'm just so thrilled. I wasn't going to be able to make tonight's session, and I knew that Nkem and Adriana and Nikki would have it all together. And I just jumped on to just show my support and learn. And every time I think like, okay, we do this work every day, like what else is going to be new? You learn something more. And then the OG GOAT, Dr. Bradley, jumps on, and you're like, I'm like girl fanning out over here. So everybody that was on the call, we definitely got a treat from Dr. Bradley, Dr. Jones, Dr. Wolf, and both of our patient advocates. Nicole, you always, always, always support us and are willing to share your story. And Ashley, we're so happy to hear your story and have you in the family. You all, we are really, really committed to making sure that we do this work that helps us and helps our community. So thank you for your support. Thank you for joining tonight. And please stay tuned. And Kim is a powerhouse at planning these things. And I just want to give her credit for all that she does to get these events going. Thank you, everybody, for joining. Adriana, we love you. Thank you so much. Have a great night, everybody.